You and I have a mutual friend.
I can't make out who that is. Is that Emily?
Yeah, that's Emily.
Oh, no kidding. That's too crazy. Yeah. Oh my God, how funny.
The opioid epidemic. How did we get here and what do we do now? We'll talk to Dr. Drew. Dr. Drew is a practicing physician and board-certified internist and addiction medicine specialist. We'll find out how the pandemic has changed treatment for those dealing with addiction. Next on Battling Opioids.
Welcome to Battling Opioids. I'm Jay Donnelly. You might know Dr. Drew from A Dose of Dr. Drew, Dr. Drew After Dark, Celebrity Rehab, and of course, Adam Carolla and the Dr. Drew podcast. I'm Jay Donnelly along with Mindy Cronk, and welcome to the show, Dr. Drew.
Thank you, Jay. Pleasure.
So let's get right into it here. We have some questions from our listeners.
Okay,
How
good.
do mental disorders coexist with drug addiction? Do they affect drug addiction treatment?
So yeah, I'll be addressing these sorts of issues at the Wilkes University presentation we have coming up next week. And there is a tremendous overlap between mental illness and substance use disorders, right? They co-occur very frequently. It literally affects tens of millions of people. And the relationship is complicated, right? If you sort of scroll through the manifestations or the relationship between the two, if you're going to have bad addiction, first of all, you have to have the genetic predisposition for that. It's a genetic disorder with a biological basis, but genes aren't destiny. And so what activates that and makes it really more severe than otherwise is childhood trauma, adverse childhood experiences. So if you have the genetics of addiction, you have adverse childhood experiences, you're highly likely in manifesting that addictive process. So there's one relationship, which is trauma and addiction. Serious mental illness, people with serious mental illness often will seek drugs as a way to try to regulate their mental illness. Obviously, that's not the most therapeutic way to go about this, but people do it all the time. And particularly schizophrenics get relief from certain medication, but then the medications, substances rather, will then have a secondary effect of activating the addictive process. And let's be clear, there's a lot of substance use excess that's not an addictive pathology in the serious mental illness category. In other words, just because somebody's using substances doesn't mean they necessarily are going to have an addictive process. They can just use substances that adversely impact their serious mental illness. And the drugs that people use so often injure the brain, or if they don't even injure the brain, they alter the biology in such a way as to bring on mental illness. Things like bipolar disorder, commonly precipitated by things like stimulants. Also, if you're using hallucinogens or inhalants, you can actually damage the brain tissue and increase the probability of precipitating a serious mental illness that you might not otherwise have had. So there's a causational link between substances and serious mental illness. And there probably is a common genetic heritage of some type. We haven't really been able to parse that out just yet, but the things that cause addiction may also overlap with things that cause serious mental illness. And that relationship between the using of substances and precipitating mental illness symptomatology may not even be a mental illness. It may just be a manifestation of the addiction. That's why in the diagnostic manual, the DSM-5, at the bottom of every diagnostic category, every diagnostic sort of menu, at the bottom it says, provided the person is not using substances or withdrawing from substances or having an organic condition that can produce these symptomatologies, because addiction can present as any mental illness you can name. So it's complicated. How about that?
So with addiction, how has the lockdowns during the pandemic affected people dealing with addiction? Because we know there's a spike in mental health issues, if not already. So what do you have to say about it?
Yeah, strangely, the suicide rate has not gone up substantially, which is sort of bizarre. We all think we're seeing that, but I'm not sure that's borne out in the data yet. But we are absolutely categorically seeing more substance use, more depression, more anxiety, particularly in the younger age groups. God only knows what we will have done when the data finally is collected on having kept kids out of school and scaring the hell out of them that if they go outside, they're going to kill their grandmother. Clearly having profound effect on those age groups, but also the effect of loneliness and isolation is having effect on all of us. When it comes to substance use disorders, I was particularly concerned when they shut down 12-step meetings. I saw my patients scattering and panicking and really in trouble when they weren't able to go in person and get the connected support they need from their fellowship. People very quickly went into Zoom meetings, and to my astonishment, Zoom meetings were quite effective. People increased their meeting attendance because they were so easy to attend. Newcomers were more likely to attend because there wasn't the threshold of showing up at a place. So Zoom meetings initially were extremely effective, but also, as I suspected, when it's not an in-person, we can talk, this is a whole complicated issue, but much of how people heal when they have substance use disorders is literally using other people's brains and brains and bodies. And if you don't have that brain-body connection in space, you don't get the full effect of the fellowship. And lo and behold, after about 6 months, we started seeing a lot of trouble. So right now we're kind of on a bit of an upswing, but meetings are starting to happen again out of doors. And so people are finding their way.
We have an 800 number for addiction and suicide. It's 1-800-662-HELP. Do we have anything like that nationally that you're aware of?
Oh, yeah, there's a national suicide helpline. There's lots of good. When it comes to suicide, there's those numbers that people will flash up, so to speak. Those suicide helplines are quite good. I can look up the national suicide number. Give me a second.
Sure. And then Mindy, we'll have a question from you if you're
go ahead. Go ahead and
Mindy, you have a question.
Yep. Hi. Thanks. So based on your experiences, are there effective ways to reduce the stigma associated with addiction and mental health?
All right. So let's talk about stigma. And I think it was nice that you put both addiction and mental health because they are different in terms of how stigma is experienced. Let me give that helpline number. It's 800-273-8255. That's the National Suicide Prevention Lifeline, 800-273-8255. And it is not I've had reports. It's not a perfunctory recording or anything. They will help you. So stigma. All right. Stigma has many different qualities to it, right? There's discrimination and stigma, and then the broad strokes are what society thinks, and then what we internalize, so-called self-stigma. And self-stigma is really the most damaging part of stigma around mental illness. In point of fact, stigma can be mobilizing. People can become an advocate on behalf of their illnesses as a way of managing stigma. And it's very empowering, and people really do very well when they become service-oriented. The stigma does not bother them. When they allow themselves to fall into self-stigma, the problem with that is they start thinking, I am impaired, I am broken, why try? That why try effect is the most serious part of self-stigma. Now, my problem is a lot of the stigma energy has been directed at addiction, drugs, and alcohol. And I will tell you, as somebody who deals with serious mental illness all the time, those are the folks that experience stigma, not drug addicts and alcoholics. I've treated 10,000 drug addicts, never had one complain to me about stigma. Because when you're in that state of drug addiction, you are concerned with one and only one thing. That is using drugs. You could give a damn about anything else that's going on. Think about it. You don't care about your work, your relationship, your families, your life. You want to use drugs. That is the distortion of addiction. In fact, it causes something, we call it denial, but it really causes a biological process called anosognosia. Anosognosia is the inability biologically to see the consequences of your action and what the illness is doing to you. We have this with stroke patients. If you have a right middle cerebral artery stroke, your left side of your body goes out, you literally don't know it. And there's no way you can know it. That's the thing about anosognosia. So to think that stigma is going to bother somebody in that state, it's misguided. Stigma bothers family of drug addicts a lot. Families are stigmatized. And there's a more subtle manifestation of stigma, and this is what I want to talk about at Wilkes, which is within the mutual aid societies, there's sort of, listen, I'm a huge advocate of mutual aid. There's now a publication by the head of the Harvard Addiction Medicine Program and the Stanford Addiction Medicine, Dr. Humphreys and Dr. I'm blanking on John's name. This is my post-COVID brain. Thank you very much. But the Stanford, Harvard put together a Cochrane analysis of the effects of mutual aid societies, and lo and behold, they are as effective as any professionally managed intervention, and they are free. What did I mention? They're free. They're free. They're free. They're free, and they're available in every corner. If we're interested in the cost of healthcare, these services are free, and they're scientifically justified. My point is, within them, though, it gets a little bit cliquey and high schooly, and people can stigmatize one another within the program. And there are people that are stigmatized for taking medication of all types, and there's different kinds of stigma. That's actually where I worry about stigma, is within the mutual aid societies. Because the addicts themselves, I've never had an addict complain. I have 10,000 patients, not one has ever complained about stigma. And it's certainly, listen, addicts will use any reason not to look at the using. Again, that's the anosognosia. And if stigma is one of the justifications, they'll grab for it. But I've not had anyone complain of that.
We have a statewide television show, Battling Opioids, that runs on 7 Pennsylvania PBS stations. And one of the questions that keeps coming up is, why is addiction a lifelong struggle? Day one.
Well, because these days, because one of the things I'm going to talk about at Wilkes is how we got into this mess. And it's my profession. We've had 2 opioid epidemics in this country. One was immediately following the Civil War that ended in the early 2 decades of the 20th century. And then another that was triggered in the latter part of the 20th century, both perpetrated by my profession. And I'm sorry, give me the question again. My train of thought goes off sometimes.
Sure. Why is addiction a lifelong struggle?
So these days, because there has been so much medically introduced, iatrogenically introduced opioid addiction, we're seeing a lot of drug dependency, meaning they look like addicts, but when they come off, they stop, and that's the end of it. That is not a substance use disorder. That is dependency. That is iatrogenic dependency. And they are hard to tell what you're dealing with when you're in the throes of somebody strung out on some things. But if somebody is dependent, has withdrawal, and then comes off, and then is really not interested in using anything ever again, well, that's not a lifelong problem. That was an iatrogenic problem caused by my peers. But if you have the genetically based disorder we call substance use disorder or addiction, that triggers a disturbance in the medial forebrain bundle that is, I don't want to say permanent because it does settle down over decades, but essentially permanent and easily reactivated. Once the so-called switch is thrown on that genetics, on that biology, and there's different theories about what it essentially is the ventral tegmental cells firing rates into the shell of the nucleus accumbens. And it's the intracytoplasmic messengers in the cells of the nucleus accumbens that have this genetic alteration that change their relationship with the ventral tegmental area and thus the outside world. So your brain has 2 systems. It has a liking system and a wanting system. Addiction is about the wanting system. Obviously, you have to like it to get going with it in the first place, but the thing with addiction is it keeps going even when you don't like it anymore. The wanting takes over. And that wanting has a lot of manifestations. It can manifest as craving, which frankly, a lot of fear of craving and treating addiction. I welcome craving because it lets my patients know their disease is there and operating, and it disturbs motivation and thinking. So people with substance use disorders start thinking all sorts of things are good ideas that is really, in fact, your brain trying to get you back to the substance, because as a motivational priority, as a result of that biological shift in the cytoplasmic messengers, the nucleus accumbens, the priority of using has gone way up the scale. And things like going to work, loving your family, survival, those, which is what that system is designed to protect, take a lower motivational state compared to the addiction. Does that make sense?
So what you're saying, though, is there a difference, though, between physical dependence and addiction?
Yes. Dependency means you take more to get the effect, and when you stop, you have withdrawal. That is not addiction. That is dependency. That certainly is a later effect of the substance use disorders if you have this thing we call addiction. And again, I'm using the term substance use disorder and addiction, sort of concurrently. I'm old school. To me, they're the same thing, having dealt with many, many thousands of people with this. But if you, and then when you stop, you'll want to keep using. In one fashion or another, you'll switch to something else, so you'll replace it. Your biology is shifted. The switch is thrown, so to speak. While if you are merely dependent, you'll stop, and that will be the end of that. You could have terrible withdrawal, but who cares? You're happy when you get through it, and you don't think about using ever again. While an addict may not even be thinking about using, but they're thinking about things and persons and places and things that get them back to using.
Mindy, you have another question?
Yeah, hi. Are there lessons from your experiences during the AIDS crisis that you apply to substance use and addiction and mental health?
Do you have something in mind particularly? I worked a lot in the AIDS epidemic.
I
Dr.
think
Fauci,
that-
didn't you work with him back in the day?
I didn't work with him, but he was my guiding light, as he has remained through this pandemic. And had we allowed him to be that for all of us, we would have been better off, and there wouldn't have been such consternation flying around him. But I'm sorry, Mindy, what are you thinking?
Yeah, I'm thinking from convincing the public messages, learning.
Yeah. So here's what I learned from the AIDS epidemic. And there's 20 years of literature that followed on the heels of this. The AIDS epidemic was a pandemic where if you got the disease, you had a 100% probability of death when I was working with it. I mean, think about that. That's not 1%, 5%, 10%, 100% probability of death. And we never sat, behind our desk saying, if you have sex with somebody, you're a murderer. Now we're saying, if you don't wear a mask, you're killing your grandmother. It's the weirdest shift I've ever seen. It's an abandonment of 20 years, actually 40 years now of literature that tells us how to do this, how to get buy-in and adjust health behaviors. And that is create a relatable source, somebody who looks like you, same age as you, a narrative around that person, look at the consequences of the choices they make. People learn from these narrative stories, and then the consequences. Little humor, little music, boom. That's it. That's how you get people to buy in. So in terms of what I have modeled my whole career off of that phenomena, Loveline was that, Teen Mom is that, and Celebrity Rehab is that. We're showing you stories of what happens to people with these conditions, and people learn a ton, and they adjust their behaviors when they see those narratives.
So Mindy mentioned stigma before. So do we need to increase education for providers to help out with the opiate problem? How do we get rid of?
Well, I mean, look, I'm fighting stigma on multiple fronts. I worked with many different societies organizations that serve serious mental illness. And believe me, other groups are highly, highly stigmatized. I feel like now it's not just education. Of course, I keep chanting over and over and over again that, the fact that we treat diseases below the neck differently than diseases above the neck, that brain diseases are different than pancreas or heart or colon. It's an organ. It gets sick. It shouldn't be dealt with any differently. So here's the things we should do. We should be adjusting HIPAA laws so the psychiatric records are the same as medical records. The fact that they're treating them differently, stigmatizing. We should talk about brain disorders no different than any other medical illness that we have out there. They should be parity, should be something that is actually in the hands of the patient and the physicians, thereby the way it is on the medical side. So there's so many things, subtle things we're doing that adds to stigma. It's uncanny. So education is a thing. Changing procedures like HIPAA are a thing, but the main thing is contact. That is how discrimination and stigma is dealt with. It is through contact. So you must reach out. I mean, certainly there are plenty of people on the streets right now you can reach out and talk to. Make contact. There's something called the uncanny valley in robot research, where we as humans like robots that look more and more and more and more and more like us until they get just like us, and then we're disgusted. Then we're repelled. And whatever that is, my sense is people have that when it comes to brain disorders. They push away, lean in, make contact. That's how you reduce stigma.
So I know you have a heart out, so that's a good note to go out on. So thank you, Dr. Drew. Where can we find you online?
DrDrew.com. It's all there. Check it all out there, and we'll be at Wilkes next week.
For now, I'm Jay Donnelly. Thank you for listening and watching Battling Opioids.